Welcome to Louisville Lectures Pediatric Emergency Medicine Lecture Series.
I'm Wayne Stark, and let's talk about cold injuries. So, to get started, this is not a lecture on hypothermia. That will be a separate lecture, so please look for that one if that's what you're interested in. Today we're going to be talking about more local findings. So with cold injuries, there's two ways that you can classify them: non-freezing, which we will start with, and then freezing, which is frostbite, and that's where we'll end today. So to start with our non-freezing injuries, you have chilblains. It's also called perniosis, and some folks will pronounce that perniosis. And what that is basically you have these irritation to your skin and inflammation due to repeat constriction. And that's often due to repeat exposure to cold air. That's really how you get it. And so they can be red or purple, although classically they're red, tend to be more itchy or painful. And there's papules, which is most common, but you can have blisters, patches, and macules as well. And so who gets them? Well, if you need repeat cold exposure, probably a cold climate would help. Although I guess you could get that if you were working in something like a walk-in freezer or some form of Gaylord ice sort of a scenario. But realistically, it's usually environmental. So who can be predisposed to them? Well, anything with vascular issues that would make vasoconstriction more of a problem for someone, particularly in their periphery. So Raynaud's and smokers and vascular disorders can all be predisposing factors. It's a clinical diagnosis. There's really no test necessary, and you tend to recover from it fully with some supportive care. So you want to prevent it by wearing warm clothing and also avoiding cold exposure if unnecessary if you're suffering from it. And for treatment, we just tend to keep them warm and dry. Warm compresses can be helpful as well as warm baths. And topical steroids and antihistamines, they may be helpful as well. The next non-freezing injury is trench foot or immersion foot. So this name, it's most commonly called this and attributed to World War I and World War II, particularly World War I trench warfare, although it was described in the Napoleonic Wars, and it's due to prolonged exposure to cold and wet. And so that leads to compromised circulation, and that leads to tissue damage. And so if you find someone who's basically got cold and wet in their feet all the time, that can do it. And classically, that's done because someone's wearing socks or shoes that are wet, they're wading in cold, wet water. Anything that really keeps the foot cold and wet for an extended period of time can predispose you to trench foot or immersion foot. And the symptoms are really based on the depth and extent of the injury. So at a minimum, they'll have some redness and swelling. But as it gets deeper and deeper and you have more profound tissue damage, it can be quite of an ordeal for the patient. So tingling, burning, itching, numbness, all of those are common presentations, and they can get painful wounds that tend to develop with rewarming. It's worth noting that with a lot of these injuries, rewarming can be painful, so pain control is a consideration when rewarming. Blisters, ulcers, even gangrene can develop, and part of that is because you have tissue injured, and the other part is that often it's kept in a less than hygienic environment in their shoe. So the most important thing is to prevent it. So keep your feet warm and dry, and they can be wet from perspiration or from wading in wet water. So what you would like to do is change your socks and keep your shoes dry, and that would be a great way to try to prevent this. However, also avoiding going through wet water and getting wet in the first place. That can do it. And if you are in a place where you are getting wet, changing your socks out can be helpful. Saw this in a patient who eloped from a facility and was basically hiding out in cooler weather in one of our local parks, and he came back with it. The people providing care to him there were concerned when they saw what his feet looked like, but one of the providers, the one that brought him to the ER, had spent time in the service and recognized what was wrong with his feet immediately. Now, treatment-wise, you want to get them warm and dry, so remove that cold, wet stuff. Warm and dry, also elevate the extremity. A gentle rewarming, we're not rubbing them hard or anything like that. Warm compresses, not hot. And rapid rewarming can be more painful, so gentle rewarming is appropriate here. We mentioned before that waterproofing and avoiding water is a good way to prevent it, as well as avoiding prolonged exposure. So if infections show up, you need to treat them. We also need to consider tetanus. There's a lot of overlap between cold injuries and burn injuries, and so anytime you interrupt the integumentary system, you do need to consider whether you should be treating for covering for tetanus. Make sure they're up to date. Also, NSAIDs and acetaminophen are appropriate for pain. They can have neuropathic pain, so amitriptyline, there is literature that supports the use of amitriptyline for neuropathic pain in immersion foot injuries. Now, depending on the depth of the injury and extent of it, they may require wound care management with a wound care specialist, even potentially surgical debridement. So, frost nip, this is the last non-freezing injury we're going to discuss, and this is the earliest stage of frostbite. So, there's a slight color change and coldness and numbness to the hands classically, but at this point in time, no injury, and so supportive care is appropriate. Now we're going to transition into a discussion of frostbite, and that is where damage has occurred. So this graphic kind of helps to distinguish the two. This one's borrowed from Mayo. And you can see on the far left that there's no frostbite. That's just normal tissue. And then two, you can see some erythema and tenderness there, and that's frost nip. That's completely reversible, no damage there. Now, when you get to 3 and 4, that's when you're starting to see damage occur, and you can see that it's extending into the dermis and even into the subcutaneous tissues. Now, with superficial, you're talking epidermis down to dermis, and with deeper, even dermis to subcutaneous. And so there's different classification systems that I wanted to discuss here. So, and we'll get to them. Now, they tend to follow the same kind of idea, and that is mild to severe based on how superficial to deep the problem is. And you can see different clinical manifestations based on the depth. So with frost nip, erythema and pain, maybe even purpura, common. But when you start to see pallor, then that's concerning that you're transitioning into frostbite and tissue damage. And even more so when it looks hard black and necrotic, concern for more severe or deeper frostbite. Now, this is a bit wordy, but frost nip and frostbite, first degree is frost nip, and that's thought to be completely reversible. And while it is irritating, it should improve with gentle rewarming. Whereas when you start to see damage is second degree, and that's more superficial. You can see blistering there, but typically no major damage, and typically it's not too profound. When you start to get to third and fourth degree is when you're deeper. The distinction between third and fourth degree being that fourth degree is more of your deep to full thickness. So with third degree, you're involving all layers of the skin, and you can see permanent damage. So that would be described as deep, whereas fourth degree deep or full thickness depth, and that's when you're starting to get to bone and tendon, and you're really at higher risk of amputation there. While there are blisters with second degree, third and fourth degree, as you get further along, you can continue to see blisters, but they can get to be more hemorrhagic, and you can even see that black necrosis that's demonstrated there in this graphic from the Cleveland Clinic. So frostbite care. Initially similar to, there's a lot of similarities to burns that really need to be discussed. We mentioned previously tetanus. So anytime you're dealing with the integumentary system, you have to consider infection. So tetanus prevention as well as infection control. And so there's a lot of similarities there. One thing that's interesting about frostbite is if someone touches a hot stove and burns themselves, you can cool them. And if they do it again, you can cool them again with cool water. Now, when it comes to these cold injuries, you really don't want to be thawing and refreezing them repeatedly, so you don't want to be doing any true thawing interventions, and we'll get into what those are, until you're in a place where you can keep them thawed. There is a lot of damage with these thaw-freeze cycles that that can lead to a worse prognosis and worse outcomes. So we don't want to cause any additional injury. So we're not going to overheat them. We're going to warm them appropriately, but not excessively. And we're not going to rub or otherwise damage this fragile tissue. So for frostbite, I mentioned previously that when they're rewarmed, they may blister. And the deeper injuries may not have just serous blisters, but more hemorrhagic. So our priorities here are going to be to minimize dermal ischemia and then to promote timely healing and those other supportive care measures that were previously mentioned. So there's 3 phases of frostbite treatment, and each of them has their own priorities. So we're going to discuss them one by one. And the first one being the pre-thaw phase, and that's more of a pre-hospital interventions. Then there's rewarming, which is something we would be doing in the ER. And then there's post-thaw, which is important to discuss, but that also goes into longer care outside of the ER. So for pre-thaw, it's often pre-hospital, you're really just trying to stop them from freezing further. So you get them out of the cold environment, you get them out of any cold or wet clothing they might be in, some soft padding to protect the area, but once again, we're not rubbing. We don't want to cause additional injury to that area. Now with rewarming, that's different. Now we're trying to warm them up. So that's a good 15 to 30 minutes. Most of the guidelines and recommendations I saw put this somewhere in the 15 to 30 minute range, 20 to 30 minute range, although there's kind of a clinical goal we'll get to. So you want to immerse them in the affected area in warm water. And so your target is 40 to 42 degrees Celsius. And this can be painful. So while you're doing this, you're going to provide IV analgesia. Opioids are kind of mainstay. Pretty much everyone seems to recommend that this will likely be painful, and so that is a reasonable use of opioids. They may need to gently move the extremity. When I say gently move, it's still in the water bath, just kind of flexing and extending and using it modestly. And the goal is that you rewarm it and you go from that what might be white or pale or even worse looking tissue, try to get as much of it as pink or purple, soft to the touch. And the blisters that we mentioned do develop, but those tend to be later. We're talking 4 to 24 hours later. So don't anticipate much in the way of blisters at this phase. Now with pulse thaw, you've taken this extremity, you've warmed it, and now it's really the wound care issue. They're going to heal, and you're going to support that as needed. So they'll need a loose, sterile dressing. Might be worth it to discuss their case with a specialist, such as a surgical consultation or plastics, or wherever we'll be doing any potential grafting or amputation. There are some burn centers that also manage these and have their own protocols. And so at this point in time, they're healing and you're seeing what further interventions they need. Now, in terms of infection control, prophylaxis is a little more controversial. It doesn't seem like that's universally recommended. But if infection is suspected, then you want to make sure you cover for staph, strep, as well as Pseudomonas, similar to a burn victim that had a disruption of their integumentary system. So we've discussed ischemia a lot, but what about TPA for that ischemia? And so that is something that is done in severe cases. And so there's different protocols, and most of the ones I can find seem to be more directed towards adults. And so what you're trying to do is avoid a life-altering amputation. So you've rewarmed the person, you're concerned that they're having extremities that are still not perfused, and there might be a benefit to thrombolysis to them. So that type of patient would be one who, we're talking 3rd or 4th degree frostbite. And when they say life-altering, there's different ways that they define it depending on the protocol, but you're talking about losing a digit or worse. And so distal interphalangeal joints or more proximal locations. So this wouldn't be something where it's just the tip of a finger, but not involving a joint or further. And this has to also be done within the first 24 hours after thawing. It's not something you wait a day and see. So while we wouldn't necessarily do it in the ER, we might initiate it. So we do need to consider it. But you don't do it in patients who have had multiple freeze-thaw cycles because the tissue damage there is different. It's not something freshly thawed we can perfuse and save. It's often very protocol and specialist driven. So this isn't something you'll likely be initiating in a vacuum by yourself. So you really should consult a specialist with the goal of this being to try to minimize amputation. And while it's not commonly done in pediatrics, I have included up-to-date recommendations there. That being said, I don't know that any of us would actually initiate this without further consultation and discussion with specialists. So right there, I've included a chart. We previously discussed severity of frostbite, but what you're considering here at this point is the severity of the frostbite after rewarming and what's the risk of amputation after that. So there they give you a grade 1 through 4 chart where grade 1, fortunately, we've met our goals. We've got pink or purple tissue, and it's all nice and soft. Whereas you can see grade 2, 3, and 4, we're starting to see that there is a risk of amputation there. Especially with 3 or 4, you can see that there's a risk of potentially losing digit or part of an extremity. And so we really need to, at that point in time, consider maybe something like TPA would be appropriate. So here are my references. Have a wonderful day.